Let's go ahead and call this meeting to order then. This is the Kern Valley Healthcare District, our regular board meeting on Wednesday, March 3rd. Heidi, you've started recording. Excellent. The first order of business is the approval of the agenda, and I do have some changes to make to the agenda. I would like to, first change would be to move new business items 1, 2, and 3. These are all the matters dealing with the bond to follow right after the consent agenda. So they would appear, we'll tackle them before item E, before the reports. And then, pardon me, we do have an item to add to the agenda as well. This is an agreement with Blue Shield to approve the distribution of, or continue the COVID distributions to us so we can continue our vaccination program. Now, Scott, I need your guidance on this. This did not appear on the original agenda. I know we have to take some special actions to put that on. If you could provide me with the language for that.
Of course, because it looks like all 5 directors are present for the meeting tonight. We need a 4/5 vote approving adding the Blue Cross vaccine contract to the agenda on the grounds that the contract was presented to the district for approval after the agenda was posted. And the district needs to sign the contract immediately to continue administering the vaccines through Blue Cross as a third-party administrator.
Okay, thank you, Scott. So I'll entertain a motion for those changes. Can we do this all in one action, Scott?
Yes, there can be a motion to add the Blue Cross vaccine distribution contract as a new business item and move the revenue bond agenda items to follow the consent agenda and approve the agenda as otherwise presented.
I'll make a motion, we do what you just said.
I'll gladly second.
Is that Fred?
Yes, sir.
Thank you. Okay, then believe here that Jean and Fred are a yes vote, and we'll do a roll call on the other 3. Director Blythe?
Yes.
Director Elkanan?
Yes.
And I'm a yes. So we're making those changes. Thank you. We need to do a flag salute, and I haven't designated anybody yet for a flag salute. And Tim McGlue, could you lead us in the flag salute?
Happy to.
Thank you.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you, Tim. And Mark, would you do us the honor of leading the invocation, please?
Absolutely.
Thank you.
For those that would care to join me, Heavenly Father, we just come before you this evening in the regular board meeting of the Kern Valley Healthcare District Board of Directors. We will be discussing items that are to better the community and to better the services that we offer to the community. We ask that you bless all the decisions made tonight. We ask that you touch each one of the individuals participating. In Jesus' name, amen.
Thank you, Mark. Our mission statement is there on the agenda. I won't read it at this time. Item C on the agenda is public comment. This portion of the meeting is reserved for comments by the public on matters under the jurisdiction of this board, but not on this agenda. Do we have any members of the public that would like to be heard this evening? Okay, I see none. Then we'll move to the consent agenda, item D. The consent agenda are a list of actions that staff does not believe are controversial. Many of these have been through committees, and the committees believe these are appropriate for board approval. So all of these items will be approved under one action by the board, unless a member of the board or a member of the public would like an item removed from consent and discussed in its normal order. Would anyone like a matter removed from the consent agenda? Okay, I see none. And I'll entertain a motion to approve the consent agenda.
So moved, John.
Thank you, Director Blythe. And we'll need a second to move this.
I'll second.
Okay.
Was that Catherine?
Yes.
Thank you, Director O'Connor. Then Director Parks, your vote.
Yes.
Director Clark, your vote.
Yes.
And I'm a yes. The consent agenda is approved. Which brings us to item E. And I know we have tonight our consultant, Gary Hicks, who's joining us from Colorado, from outside his baseball field. So we have him here tonight to help us with any questions we have on the bond. I see Chet is on the telephone, but I'm not sure who's actually doing the presentations. Are you doing these, Tim?
Oh, okay.
Actually, I think I'm going to ask Gary if he would walk us through these to do that, unless Chet is capable of doing that. I have not spoken with him today.
Okay, we'll take one at a time, and this is Resolution 2101, resolution approving the form and authorizing the execution and delivery of an indenture of trust and a bond purchase agreement in connection with the issuance, sale, and delivery of Kern Valley Healthcare District revenue bonds, Series 2021,
It's not in the packet. It's also supplemental.
and approving certain other actions. So item 1 under the new business.
Thank you very much. This is Gary Hicks. As indicated, the initial resolution is one of 3 to go before the board this evening. It relates to the revenue bond issue, which is the dollar amount of that is $12,616,000. It includes a refinancing of the 2013 revenue bonds that the district has outstanding. The loan with what we call the Heathcliff Fund, which is the Cal Mortgage Oshpod loan, and funding of an additional $5.5 million in new money for the new project at the hospital there, including reimbursement for costs associated with that project, the purchase of a new administration building, which I believe was purchased here a while back, so reimbursement of that, and also the reimbursement and purchase of capital equipment of the district for the district's health facilities. This resolution is a final resolution, so it's a final board authorization for the district to proceed forward with the issuance of the debt. The purchaser would be First Foundation Bank, so this is a private placement with First Foundation Bank. It's a loan that would be at 2.75%, amortized over 13 years, fully amortized over that 13-year period, and is a financing I think we reviewed not at the last board meeting, but also has been reviewed, I think, the last finance committee meeting. You've been provided, I believe, at that meeting with a final term sheet that lists all the terms and conditions of that financing, but they are very favorable in what we received as far as responses, and very favorable from any perspective. But this resolution, if approved by the board, would authorize certain district board members, the CEO and the CFO, to execute the documents indicated, primarily the indenture and the bond purchase agreement, and to execute any other documents needed to carry out the intent of the resolution, which is to close and fund the 2021 revenue bonds. It also authorized any other actions necessary to be able to, again, carry out the intent of the resolution. So that's kind of a general overview of the resolution with respect to the revenue bonds. I'd be more than happy to answer any questions you may have and answer those to the best of my ability.
Thank you, Gary. Does any member of the board, well, let's start with the public. Does any member of the public want to be heard on this issue? Okay, seeing none, then we'll turn it over to board members for discussion. Feel free to provide your comments, your thoughts, or questions directly to Gary.
Hey, Russ, can I ask him a question? I know the answer, but apparently I understood that all the meetings we're at were recorded and posted, and apparently they're not. There's no information period out there. So I just want to, at this meeting, if we want to take out another loan, can we?
Yes, the indenture that you would be executing for this financing does have provisions for what we call additional indebtedness, which is the ability of the district to issue new debt, whether that be revenue-based debt, which this is based upon a revenue fund pledge, or any other type of debt of the district, whether it be equipment leases or other type of debt secured by taxes. You have flexibility to do that. With respect to the revenue bond debt, it would require, or for that matter, equipment leases, it would require that the district meet certain financial tests to be able to issue that debt. Those financial tests would demonstrate the ability of the district to be able to repay not only the existing debt that's outstanding, but the new debt that you look to issue. But yes, provisions are set forth in the indenture for this purpose.
Okay, that's pretty much my question. If we got into trouble, let's say the next few years was lean and we couldn't make the payments, what would happen?
Well, the lender, which is First Foundation Bank, would work with the district to be able to help you to be able to make those payments. Obviously, it is an obligation. The worst case scenario would be that they do have the ability to take control of your demand depository account, which is your main checking account where the district deposits its revenues in. That's where the security interest is in. They have the ability to take control of that. That very seldom is the ultimate outcome of that because they really don't have a great deal of control at that point in time. And so usually they just work with the district, usually require the district to engage the services of an outside consultant, a management consultant, to review its operations and how it's operating and how better to maybe change how it charges for services and whatnot. And it would, to the extent that it's in the best interest of the district, it would request that the district follow the recommendations of an outside consultant so that it improves its operations sufficient enough to be able to meet its debt service obligations. The district is not providing any security interest in its real property, or for that matter, personal property for this financing. It's strictly a revenue fund pledge, which is a security interest in its demand depository accounts.
Okay, you're familiar with our hospital. You're very familiar with it. Would you recommend what we're doing is a good thing? I think you do by being here.
Yeah, I wouldn't be here tonight if I didn't recommend it.
Okay, all right, thank you.
Any other board members have questions or comments?
Yeah, Gary, and you were here back in 99, 2000 when the hospital defaulted on its bonds, right? Because you've been a consultant here for like 30 years, I believe, or somewhere around that time.
Yes, I think that's correct. I mean, in fact, I was your financial advisor in the issuance of those bonds as well.
Okay, and so with this, I mean, this is essentially getting us out of the control of Cal Mortgage because they have the obligate or the rights to the assets like the building, and this kind of gets us out from under that obligation, correct?
It does. Cal Mortgage is a state agency. They have special legislation to have a security interest in not only your real property, but your personal property as well as a revenue fund pledge. This would, part of this financing would be the recording of a deed of reconveyance, which would remove their security interest in your properties that you own, as well as releasing of all their security interests, not only in the real estate, the equipment, and the revenue fund pledge or demand depository account as well. So yes, it does do all of that.
I don't know about everybody else, but I'm really excited to just start moving forward on this. It's been a long time coming. That's just my opinion.
Yeah, the only problem I have is if, for an example, what we could do right now, if we just paid off what we owed, we'd still have 4 or 5 million to work with and then pay for it as we earn it. I feel like we should earn it and not borrow it, but that's my feelings, and I'm probably wrong apparently because everyone else seems to be in favor of borrowing. So thank you for listening to my comments.
Thanks, Dean and John. Okay, are there any other items to discuss on this agenda item? Okay, then I will pull the board. Oh, I will need a motion and a second to approve this.
Wouldn't we do them all 3 at once? We do them one at a time?
One at a time.
They're listed separately on the agenda, so we'll take actions for each one.
And Director Elliott, for the roll call for this, will you go through all 5 directors, please?
Sure.
Thank you.
So Ross, I'll move to adopt resolution 2101.
Thank you, John. Do we have a second?
I'll second it.
Thank you, Gene. Okay, then I need to poll our board members. So Director Blythe,
Yes.
Director Parks,
Yes.
Director Elconin,
Yes.
Director Clark,
Yes.
and Elliott is a yes. So we'll move to item number 2 under new business, resolution 2102, resolution approving the form and authorizing the execution and delivery of a line of credit agreement with First Foundation Public Finance, a Delaware statutory trust, and a wholly owned subsidiary of First Foundation Bank, and approving certain other actions. Mr. Higgs.
Thank you. This second resolution is similar to the first resolution in that it provides final approval of the district's board to enter into a $5 million line of credit with First Foundation Bank, or a subsidiary as indicated with First Foundation Bank. This is related to the revenue bond issue, and that the revenue bonds that are insured by Cal Mortgage that are outstanding, the 2003 revenue bonds, also have a line of credit associated with it that is also insured by Cal Mortgage. Cal Mortgage indicated that when they are paid off on both the loan and the bond issue, that they would not be willing to continue with the guarantee of the outstanding line of credit, I think with West America Bank. So this replaces that outstanding West America Bank line of credit. It's a 2-year line of credit. I think the West America Bank is a 1-year line of credit. It does not require Cal Mortgage's insurance or guarantee for the transaction. And so it provides you to move forward with the revenue bond issue and still have the desired line of credit outstanding for the district in meeting, whether it be ongoing operating needs of the district or to meet any other type of IGT funding that it has used the outstanding line of credit in the past for. It does authorize certain district officers and or district board members, excuse me, and the CEO, CFO to sign documents, the line of credit and any other related documents, and take any other actions necessary to be able to fund and complete the issuance of that $5 million line of credit with First Foundation Bank subsidiary. Again, more than happy to answer any questions you may have regarding the line of credit.
Thank you, Gary. Are there any members of the public that would like to be heard on this item? Okay, I don't see anybody coming forward. And I will turn it over to the members of the board for your comments or questions.
Can I ask a question, Gary? So for operating funds, if we could get something for 1%, would we be required to go to that year's first? Or could we borrow money on our own for operating?
This line of credit does not require you to utilize it at all. So if you have other access to other capital, or you wish not to use a line of credit, there's no requirement for you to do it. It's available to you if you so wish to do so.
Okay.
But I think the answer to your question is you can borrow other money if there's a lower cost of financing than under the line of credit. You're certainly able to do so.
Okay, thank you.
Gary, my understanding was too that the West America Bank was limited to only providing the IGT payments for the hospital in order to get those funds. My understanding is this does not have those same restrictions.
Tim, you're absolutely correct. As indicated earlier, it's for all working capital purposes of the district and any needs. It also, since it's secured by a revenue fund pledge, identical to the revenue bond issue, it does not require that you have security is provided in your accounts receivables. Does not require you to be able to monitor the accounts receivables and the delinquency or the term of those accounts receivables, and doesn't require any type of calculations with respect to your accounts receivables to be able to draw down money. You can use it for any legal purpose, operating purpose of the district, whether it be for IGT funding or otherwise. More flexible, certainly, than your current one that you have outstanding.
Can I ask one more question?
Go ahead, Gene.
Why isn't Chet saying anything? Is he there?
Chet.
He's on there.
Chet's here. He had a medical procedure.
Oh, okay. I see his.
I'm here.
No,
Can you hear me?
I understand. Thanks.
Yeah,
Matt.
I just explained what's going on, Chet, so
Thank you.
you're good.
All right, thanks.
Any other questions?
Okay, I'll entertain a motion to approve this matter.
I'll make a motion that we accept this and adopt it, the
Thank you.
resolution.
Thank you, Catherine.
Can I second it?
Thank you, Gene. Okay, then I will poll the board. Catherine Elconin, your vote. Yes. Gene Parks,
Yes.
John Blythe,
Yes.
Fred Clark.
Yes.
Ron Elliott is a yes. Which brings us to item 3, Resolution 2103, resolution approving a debt management policy. And Gary, if you could give us some background on this.
Sure. This is a state mandated requirement. It came into play, I think, on January 1st of 2017. It requires any public agencies other than state agencies, like many state edicts, it doesn't require them to follow it as well. But it does require special districts like Kern Valley Health or Hospital District to issue this type of a debt policy, a debt management policy. It's not a bad policy at all. It's actually a good policy because, in my opinion, because it's kind of the best practices for it, whether it's a public agency or a nonprofit entity in the issuance of debt. So it sets forth expectations as to when you might want to issue debt, steps you might want to take before issuance of debt. It refers to both long-term debt and the issuance of short-term debt. It talks about limitations on use of things like derivative products such as swaps, interest rate swaps, and others, and restricts or limits you in the issuance of those type of more risky type of products related to debt. So I would consider it to be kind of a best practices for public agencies on the issuance of debt. And so it is required by any public agency when they do issue new debt that's tax exempt debt like this, that they also pass a debt management policy. This policy can be amended in the future. So if the district so elects a month from now, a year from now, 2 years from now, to amend this because they find something that may be either too onerous or not in line with what their own policies might be, then you certainly have the ability to be able to amend it in the future. So it's kind of a starting point from that perspective, and can be used by the district moving forward in the future for the issuance of debt at some later date in the future. Again, more than happy to answer any questions you have about it.
Thank you, Gary. Are there any members of the public that would like to be heard on this matter? Okay, I don't see any. So I'll turn it over to board members for questions and comments.
I don't have any.
No, I'm okay with it.
I have no questions, Ross.
Okay,
Can I make a motion, we accept it as presented or proposed, however?
thanks, Jean.
I'll second.
Thanks, Catherine. So just a clarifying question I had, Gary, there's no, if for some reason we find something in there that we would like to amend or change, this is simply an action that's totally within our discretion. We don't have to go through First National to seek their approval of changes to this policy?
None whatsoever. No, it's entirely a district policy, and you can amend it and change it at your sole discretion at any point in time in the future.
Thank you. Okay, then I'll pull the board for your votes. Director Parks,
Yes,
Director O'Connor,
Yes,
Director Blythe,
Yes.
Director Clark,
Yes.
and Elliot is a yes. We added the Blue Shield contract and didn't really place it on the agenda. So let's go ahead and tackle that now.
We need any more questions for Gary or whatever, in case he wants to step off or.
Thank
I'll
you so much.
excuse myself in
Yeah,
case
Gary,
there's any
please.
questions.
thank you.
Thank you.
Thank you very much.
Appreciate all of yours.
Thank
Everyone.
Gary.
We'll talk to you soon.
Thank you so much. Bye.
Bye. Bye-bye.
Okay, so we have an agreement in front of us tonight for consideration. This is an agreement with Blue Shield to continue to receive the COVID vaccines so that we can, members of our community, our patients, the people that we take care of. This item needs to be executed before we meet again as a board, so it's important that it be placed on tonight's agenda, which we did, and approve it if we want to continue to receive COVID-19 vaccines. So Tim, I will turn this over to you if you want to provide
Sure.
any more background.
I will. Yeah, the state, as everybody knows, contracted with Blue Shield to oversee the vaccine management program for the entire state. In doing so, they've made certain requirements of everyone in terms of they're going to control appointments into the system. They're going to control access and how information flows out of this thing. One of the things, in order for us to continue to receive vaccines, we must be a signed member of that agreement as part of their provider participation group. And so Blue Shield, and we just got this contract yesterday. Greg has actually been trying to get this for quite some time from them without luck. CHA sent me a notice yesterday morning that, hey, here's the contract, which I immediately sent off to Scott and to Greg to take a look at. Like I said, they are not allowing changes to this contract. So this is just a standard boilerplate contract that everybody has to sign. And if you've had a chance to read through it at all, you'll see a lot of things in there that have no application to us whatsoever, which is not atypical from some of these government contracts. It is, like I said, they want these all done by March 22nd in order to get the network off the ground. From what I've been told as of tonight, I had a CEO meeting with Vince Vaughn also this evening. They want to get this thing going like ASAP. They will be forwarding us the onboarding package tomorrow morning. And so we can actually get that enrollment. I also spoke with them about the fact that our hospital is not listed as a vaccination site on the state's website or the counties. And so that they're going to be working on. Some of that won't be helped with the onboarding process. But apparently a number of the hospitals that were on the call tonight were in similar situations. And so none of them had received the onboarding packets or the contracts either. So like I said, because of the due date of when they're trying to get this thing in order to roll this out, we needed to get this approved this evening in order to get this back to them to get on the provider panel. My understanding is that the county tonight shared with us that they had in fact received about 145,000 more doses this week in their allocation. That will be the last that the county gives out to us. Beyond that, we can continue to give second doses if we have people that we've given first doses to that haven't been vaccinated yet. Beyond that, without this agreement in place and without being on their panel on their website, we will not be able to give out any more first doses. So it's rather important that we do this.
It sounds like what I know about it could be a very good thing, because if they're taking over all the calls, we're getting more calls than a lot of areas that are getting more doses than we are. So that should balance us out to where we're getting on our demand, we're getting as much as we need.
I'll share some of the issues. Heart Hospital is on the program. They managed to get on it somehow quickly. Kern Medical also was on it. Neither of those hospitals are showing any available appointment dates or times. Primarily, Heart Hospital said that, again, you have no control over this. They put it up, all of their available appointments were booked in 20 minutes. And then it locked them out and knocked them off the system, so you couldn't even select them or see them, And so that was a huge problem. Same with Kern Medical. They're doing theirs at the fairgrounds and stuff like that. They were knocked out. Doesn't show any available dates or times or whatever. So the other big issue that we were informed of tonight was the fact that the state has mandated through the governor that 70% of the vaccines must go towards seniors, obviously other healthcare employees, and then 30% were to be used for teachers and ag workers and food service and those kinds of things. The problem is that even though the website that they are registering these people on for My Turn collects that information, it is not linked to the appointment scheduling system. So, for example, just today with all of the appointments that Heart Hospital did have, they had a clinic going while we were in our meeting. 65% of the people who were getting vaccinated that day were in the ag and food services businesses, not seniors. There is no way for the system to define that 70% of the appointments have to be for seniors and 30% for everybody else.
Yeah,
So that's just a huge, huge mess. This thing is going to
But
be.
it should get corrected through them, right?
It will in time get corrected. Yeah, it's just, like I said, it's just such a quick, rapid rollout that there's just a lot of nightmares going on. Greg can certainly relate some of the things he's heard.
In regards to, we struggle with lots of these things all the time. One thing I did want to say about the contract is that there's a lot of requirements in this contract, and we're already 100% compliant with all the requirements. We can bill, we don't hold people accountable if they aren't able to pay. We don't segregate based on financial class or if someone were on BFMC and that was a prime contract for us, we don't make any, whoever calls goes on the schedule, and we so I just wanted to make that comment about we're already in complete compliance with the contract with our standard operating procedures.
One thing they did say that they said, be sure you're very careful when you set up your appointment times. You can add more times, but you can't take them off once you put them on. And also once they load them in there, they're going to start it, and you don't have any say over when that starts.
It's a huge Excel spreadsheet.
Yes.
Every day that we're having a clinic, for every single day, we put all of the information in.
Yeah.
So it's a very, very tedious process.
But that could be a good thing for us from what I'm hearing.
The county is happy with the way that things are rolling out. It's going to be a little bit of a struggle for us in capturing billing information, but we'll make it work.
So the ones that got one shot, we can continue with a second one.
Yeah.
What about our list?
That's going to be tough.
That's going to be, I'm glad you brought that up, because that was a question we talked about earlier today. Because many of us, the other hospitals as well, were creating their own appointment schedules and stuff like that. Well, Brent, my turn, when they turn this thing on, basically they're now taking appointments on. So we're sitting here figuring, how the heck do we get our list into that system?
How many do we have? Is it 1,000 or 500 or 20 or?
It's really hard to tell exactly how many people are on the list because we've been going through, we've had up to 900 numbers on this list, and many of those people are repeat callers. Many of those people have already had their shots by us or by other providers. So we're going through, Deb Hess is making phone calls, kind of preemptive phone calls that is kind of giving us the prime people to schedule. We're
reschedule on theirs. I'd be happy to volunteer too to do that because people are going to get thrown out in error if they think they're on a list and they're not.
My concern, like I said, from my perspective is like I said, we've got people who we've put on our list, and if we don't get them off our list, they're going to go in wherever they get placed in when the new system comes up.
But
so they could be waiting for 2 or 3 months for us to give them a shot. And then now they're going to have to wait again when the new one comes in. That was my concern.
Are most of our seniors or there is some teachers or how?
So we're maintaining 65% are either 65 plus or are in one of the early phases and tiers. We do have teachers that we vaccinated last week, and we're doing some this week. It's about 68 teachers, educators that we have or will be immunizing, which is less than 30% of our vaccinating volume. We're required to report that now to the state as well, how many educators we're administering. President Biden today thought that it's feasible to vaccinate every teacher with at least 1 dose by the end of March.
But it seems like there should be a way to incorporate what we've got into their list. There's got to be a way.
We can enter people directly. We can schedule people directly.
Oh, okay.
But
if you need help doing stuff.
See, the problem is we have the data that they've given us, but the appointments, we haven't set the appointments up yet. I don't know if you've got people that are already booked. How far out are you booked?
We are not allowed to book anyone unless we have either vaccine in our hand or specifically allocated and being shipped.
Right. So that there's
vaccine availability is not our biggest problem right now. It's a little bit. We have the opposite problem right now. That's why we're doing an extra vaccination day this week, because I received more vaccine than what I was expecting. So we're in a good position for that. We're just trying to get people scheduled.
Whatever we can do, and I say whatever we can do to make sure that we don't let somebody slide through that.
That's a big thing.
Well, whatever, we'll do it, right?
Yeah, we've done, by the end of this week, we'll have done about 1,250 first dose vaccines to people in the community. So that's a very large percentage of the community. You know, what's the community about? 14, 15,000 people. That's a very large amount that we've done. And, you know, most of those are in the senior group. We haven't started doing too many of the other educators and food service workers, agriculture workers. So.
And as of March 15th, they're adding some things in, correct?
They're anticipating that they're going to open up to people between the ages of 18, well, technically between 16 and 65, who have predisposing medical conditions for more serious COVID infections. So
there's a specific list of those.
So it hasn't, yeah, there's a list of conditions, but that's not official yet. But it's the governor announced a couple weeks ago that he anticipated releasing that on March 15th.
The Johnson & Johnson one, is that going to be a better one? Where's one shot? And how do we access it in any way, or do we require it?
The county is going to be receiving those as well, and those will be distributed out to hospitals.
I mean,
when they get those.
Do you request it, or that
they were allocated, doses were allocated to Kern County for the Janssen. Janssen is Johnson & Johnson. They're synonymous. We received allocations to the county. I had the request just before I came here, and they right now we're in the position where we can request vaccine because I have enough vaccine. After this disbursement is done, which it'll go fast in Kern County, there's other places that need it more than we do right now. It'll be another 3 weeks before that vaccine is available.
Well, as far as this, we got to sign it no matter what.
Yeah.
And I'm saying, if you need help, we can get you help.
Okay.
So all you got to do is say do it, and it'll get done. If you need help, right, Debbie? She can do it.
I want to appreciate, Ross has been actually down there at the vaccination site and volunteering his time, done quite a few of those already. So
what about a category for older, not so smart people? I'm trying to find out where I can fit in.
By just being older, you fit in already.
Oh, okay.
One of the things that was, hey, Tim and Greg, one of the things that I think we need to figure out as we transition to this My Turn thing is there are a fair number of our residents, our seniors, that don't have internet or can't use it. They don't understand it. They're not capable of dealing with the technology. We need to be able to make accommodations for those people and somehow schedule them an appointment through a telephone. So I don't know if that's us doing the data entry on My Turn or how that's going to work, but
we have the ability to do that, just like we have the ability if someone were to walk up for a cancellation, that we can register them right there. It is more labor intensive for us, so that's a little bit difficult. The way we have it set out is really good. We have a vaccinating nurse, we have a PA that interviews the patient. We have a registrar outside, typically outside of the clinic, and then we have kind of our runner. I call him the fourth wheel, and Ross has been the fourth wheel many times. So thank you for that, Ross. But they're kind of going and interacting with the public, making sure they have their forms and that type of thing. So right now our system is working pretty well.
Would the person working at that desk be able to schedule an appointment for somebody that walks up and doesn't have internet access, or should they be calling that special hotline?
We're really going to have to see what it really looks like. Like Tim said, I've made multiple attempts to contact the state, My Turn, and I've received emails back acknowledging that we haven't received any information yet. So we've been given reassurance that we will be onboarded with that system soon.
Yeah, Heart Hospital this weekend had a open vaccination day on Saturday for seniors, where it says just come on down, and they had like 6 people there on iPads signing people in and getting them. They said be real careful with that. The iPads are very slow, even down there with 5G. So he said it's better to get them to use the system if you can. But for other people, like I said, yeah, absolutely, they've called in and they've set them up on the system like Greg was talking about. We can collect that information. And then they had like someone there that was just making sure that they brought the evidence that they have their insurance and those kinds of things so that we can get copies of that stuff.
Tim, can I say something?
Sure.
I've been calling folks, and it's amazing how many people I call are neighbors calling for their elderly neighbors. So there are people taking care of people up here. I'm sure there's others that'll be missed, but I was surprised at the high number of folks that were calling for either their grandparents, their parents, or their neighbor.
Yeah, I've got an office right across from where she's at that we could use if you wanted to put computers and tables and let people do exactly what you're talking about doing. You're welcome to use it, Debbie, or
And we'll talk about that and see what we can do to figure it out.
it's got plenty of parking. It's accessible.
Okay.
And signage.
Well, that's Kay's old room or the old.
Yes, yeah, the old building, so
Okay.
we could use that, yeah.
Yeah,
yes.
that's, well, thank you, Dean. That's a good idea. People need to use that.
So Blue Shield, they're recognizing that Kern County exists. That's a county.
Yes, they did.
Okay,
Actually,
good.
in the first wave of implementation, Kern County, the Central Valley counties are in the first wave for implementation.
All right. So any more discussion on this contract?
I make a motion, are we over discussion?
Go right ahead.
I make a motion that we accept it, sign it, or whatever needs to be done to it.
I'll second that, Ross.
Thank you. Okay. Any other discussions? Questions? Okay, then I'll pull the board. Director
Can I
Park,
make a comment before you do that?
Nope. Go ahead.
Comment about Greg Davis is awesome. I can't say enough about that clinic. Everything they do is good. So anyway,
You ought to see them in action. They are a phenomenal team, and they are hitting it out of the park every day.
anyway, I'm sorry. Yeah, did you? If you said me, yes.
Okay. Director Park,
Yes.
Director O'Connor,
Yes.
Director Blythe,
Yes.
and I'm a yes.
Thank you.
Okay, so that brings us on the agenda to item E, the reports, and we'll begin with the foundation report. Do we have a rep from the foundation?
Good evening.
Hi, Debbie.
How are you? We have some exciting news. The foundation received a donation of $10,000 from an individual who has second property up here, second home up here. The money's been designated to go to help people for food. And so what we've done is we'll be working with God's Storehouse, we'll be working with the Soup Kitchen, and we will also be working with the VFW. So we'll be meeting with some of those folks next week, presenting them with some checks and hopefully have some pictures in the paper. That's our newest thing that we're doing for the month of March. And then April, of course, we're going to be having our take back medication, and that's scheduled towards the end of the month. Any questions?
I have one question, Debbie. Could some of that money be used for the diabetic clinic also?
No, it cannot.
Okay.
However, I do need to, I'm going to go ahead and write the grant for this year for the diabetic clinic. I think it's due next week. Hopefully we'll get funded again, and that's at $2,000.
Thank you, Debbie. Okay, the auxiliary report. Is Mrs. Rupert present?
She is not. She sent me a text message that she said things are going well. They, I guess on Monday had a $3,400 day down there, which is one of their biggest ever. So they continue to do great with their 3 days open a week, as well as we were doing when it was 5 days a week, which is certainly good because it's given them a break in between and allowing them to kind of clean up in between So it's been very, very effective. They continue, again, because we can't open the gift shop here at the hospital. They do put out a basket of snacks and so forth for the staff. It's an honor system they pay in, and that's been generating about 100 to 120 bucks a month as well. So again, they just said that they're continuing on and they're very happy. You know, I know Mark's got some things he'll talk about a little later that we're going to go back to them for some support on. But they are very pleased with the way things are going. So that is their report.
Thanks, Tim.
You're welcome.
Okay, item 3, medical staff report. Dr. Finstead.
Thank you, Ross. So February was a busy month for medical staff meetings, starting with infection control on February 2nd. That was a regular meeting. They reviewed the regular monthly and quarterly reports, including the hospital-acquired infection reports for acute and skilled, Foley catheter usage, services hand washing, and the clean trace audits. Infection control also had a second meeting later in the month on February 23rd and reviewed and approved the annual infection control programs and plans, as well as their annual comparative report of infection control monitoring. The Pharmacy and Therapeutics Committee met on February 8th and discussed COVID-19 related issues, along with the high-dose influenza vaccines for this coming fall. We discussed a prospective addition to physical therapy treatments. We reviewed and approved one policy from pharmacy. We reviewed the formulary under the medication formulary underwent its annual review, along with some additions and deletions. And then the committee reviewed the regular reports, including the medication error prevention program, their monthly report, medication shortages, Foley catheter usage, surgical site infections, and hand hygiene reports. The skilled nursing facility had their monthly quality improvement committee meeting on February 11. They reviewed several policies, approved 3 of them regarding meds brought in by patients, the emergency medication kit, and the pharmacy hours and medication delivery schedule. They also reviewed and approved their infection control programs and plans, reviewed their regular reports, including the CDPH plan of correction tracking, the skilled quality of assurance programs, hospital-acquired infections, hand hygiene. And then after that part of the meeting, they had their antibiotic stewardship component of the meeting. They reviewed and approved a policy regarding that program, the antimicrobial stewardship program, and then reviewed reports on antibiotic usages for urinary tract infections, wound, and respiratory infections. The Emergency Department Committee met on February 19th, reviewed their statistical reports from or through January 2021, approved a policy regarding some details regarding the physician coverage, particularly the hours involved in that, reviewed their regular reports, including blood culture analysis, risks and benefits of transfer, and their emergency department clinical quality measures. There were also some discussion regarding refill of chronic pain medications for people, and it looks like they're moving forward with going to move forward with a policy regarding that. And then reviewed the acute stroke protocols, along with reviewing some of the authorization or the indications for the authorized COVID-19 medications. Some of these are under the emergency use authorization, and the guidelines for use are quite strict on those, more so than a fully approved medication. The Medical Executive Committee met on February 23rd, reviewed and approved 7 policies. We reviewed and approved the infection control programs and plans for both acute and skilled. The utilization committee review committee met on February 24th and discussed issues regarding denials of payments and authorizations for admission. One comment was that it appears that Dignity Health programs are maybe refusing admissions and transferring those patients to Bakersfield. Reviewed the new patient portal and reviewed some of the clinical measures they keep track of, including the use of Lovenox for deep vein thrombosis prophylaxis. They also reviewed their regular reports, including medical record studies and their monthly worksheet. And then finally, the surgery committee met on February 26th and reviewed and discussed their current quality improvement project, and then also discussed a new project for this coming year. And that's the end of my report, unless there are any questions.
We have one question for you.
Sure.
So I don't know how much of this is factual. I've been reading reports that they're really the cases of flu this year are down drastically from prior years. And I guess it's being attributed to social distancing and mask wearing and
I can speak to that, Ross, if you want to know. We've had one case through the hospital since September.
Wow. So it really is true here too, huh?
Yeah, we had indications of this in the fall when we were, as a country starting to do the influenza vaccines. That information came from Australia and New Zealand, who are finishing up their winter. They noticed a dramatic decrease in influenza cases, and like Mark said, we have seen the same thing here. In fact, I had a patient ask me about that today in the office, and like, yeah, wearing masks makes a difference in lots of different things.
Wow. Wow.
Things.
I wonder then if, I imagine public health will probably get on board with that next year, but maybe that's something from a prevention standpoint that we need to consider taking on next year in promoting.
Well, it's interesting, Ross, with our staff, because obviously we either have to get the influenza vaccine or our employees have to wear a mask the entire time they're in the hospital. And we have had some employees that have decided to wear the mask. Interestingly, this year, I think we were concerned because of the mask requirements that we would have a lot of people that wouldn't go for the vaccine. But I don't think that turned out to be the case, Greg.
There's a small decrease.
Yeah, but there's still a lot of them that did get it, so.
Yeah.
So one of the big issues with the influenza vaccine, the way we currently manufacture that, is even in the manufacturing process, the accuracy of the final product gets degraded through that manufacturing process using the egg model. They have been working for quite a long time, basically on a universal influenza vaccine that targets the virus in areas that don't change. And I think that what we've seen with the mRNA vaccines with Pfizer and Moderna, that platform they've been working on for quite a number of years. This is the first time we've seen it implemented. And I think that holds great promise for, a significant number improvements in vaccines, just in general, like particularly for influenza, being able to develop an influenza vaccine that has efficacy above the 20 or 30% that sometimes we see. I mean, the mRNA vaccines basically are 95% effective. Our influenza vaccines are very ineffective. So hopefully what we'll see is, as time goes by, that they'll develop a better influenza vaccine, and we can really make an impact in that.
Great. Any other questions or comments for Dr. Finstead? Okay, thank you, Dr. Finstead.
My pleasure.
All right, then I'll turn it over to Tim, our Chief Executive Officer report.
Great, thank you. Just a quick update on COVID. I'm not going to get into it because Mark's got stuff he's going to talk about. The big thing I want to talk about is our contract extension for testing will go to the county at their next board meeting. The county's been delayed in getting that through. It will be retroactive back to the beginning of December. Prior to that, our last renewal with them was a max limit of $350,000 in support. This new one will go through for $1 million. And that is to take us up through the end of March. Because we have seen a substantial decline in the number of people who are getting tested on a weekly basis, our thought at this point in time is that if that does not change, that at the end of at the end of March, we may go ahead and just not renew that agreement with the county. And therefore people can go through their primary physicians or whatever, or to other sites to get the vaccine. What we really want to do is to focus using our personnel that have been geared towards doing that program and move them into the vaccine program so that we can get more people vaccinated. So right now, to me, that thing seems to make a lot more sense and focusing on that protection than the testing. So like I said, we still do have the ability to do certain testing here in-house for patients that show up, while we don't really want people coming to our ER to get tested. There are other means for having that done. So we'll continue to monitor that, and depending upon if there's anything that happens within the community, if we start seeing another increase, another surge coming and so forth, then we obviously would go ahead and probably extend that agreement. But right now, the way it's going and what everybody on the call earlier tonight kind of indicated that they're all seeing the same thing. It's dropping off dramatically. So I think there's so much effort and people are just really focused on getting vaccinated. And so I think that's really where I want to focus our staff's time on trying to do that. We have gotten our in-house PCR testing machine up and running. It's been working now for about a week or so, getting good results out of that, and pleased to finally have that going. Dr. Finstad brought up the issue with regards to dignity. One of the things that we've noticed over the last 2 months or so was that more and more of our patients coming through the hospital, both in our ER and patients that need to be admitted, are being told that they have to go down to Bakersfield, to one of their facilities, and so forth. Even patients, like I said, even that come to our ER, like I said, normally we would have a patient that would come in and that needs to be admitted. If it was beyond our capabilities, we would just start going through the rotation of making the calls to find out who had a bed. Dignity has bought up through their medical group a lot of the smaller health plan or medical groups in Kern County. And now to a point, like I said, where they are basically being very restrictive on terms of who has access to those contracts. So I know when we tried placing a patient the other day at Adventist Health, and they basically said, nope, that's a Dignity. We're not even going to touch them. He says, because they won't get paid if they accept that patient, even though that patient requires a higher level of care. And this has been a big concern. I mean, Mark and I have had some ongoing conversations about this with our ER physicians and our hospitalists. It's just not right. And what's happening right now, like I said, is we've got patients who've been in here. Mark, what's that? 39 plus 40 hours?
No, that lady was in our ER for 44 hours on a wait list at a Dignity facility.
Right.
And we were not allowed to look at other facilities to see if we couldn't find an ICU bed for her.
Right. So just truly a breakdown in care, and again, because people are looking at us as, hey, I need to get into the hospital. I need to get cared for. I had a call with Ken Keller yesterday. I shared my deep concerns over what's going on with Dignity. One, flat out that they're refusing patients who are more than capable of being treated here, that they forced to go on a patient with a colitis, that they forced to go down the hill. And he said, that is not supposed to be happening. So I shared with him the issue we have now with patients are backing up in our ERs. At one point, we had 5 patients waiting to be transferred. All of them were through dignity provider groups, through IMG or QualCare or whatever, and so forth. And I just told them, I said, this got to stop. I said, the bottom line is there's got to be a time limit. You either have a bed or you don't have a bed. And if you don't have a bed, then you've got to allow us to get that patient to another hospital, especially if they require a higher level of care. I said, because otherwise we're going to get stuck with it. And, that, or we're going to have to make some phone calls and so forth. So he's working on it. He promised to get back to me tomorrow and with an update as to what's going on. But he said, absolutely, under no circumstances are they to be blocking anything that we can take care of in our hospital. So that he was calling to demand that get fixed immediately. Like I said, I told him, I said, listen, I have no problem, for a higher level of care. I said, we've been sending patients down there, forever. We understand our capabilities and stuff like that. But for crying out loud, don't take business away from us that we can handle here. So anyway, I'll give you a follow-up on that when I hear that. And but I've made them very aware of our concerns of how that's going. And I shared, again, I relayed the circumstances of what we were told at Adventist Health. I said, when Adventist won't even take a patient now, that's assigned to one of your groups. I said, that's wrong. If you can't, right now when you get issues, because right now they're overbedded and stuff down there now, or they're, got too many patients down there. You can't get them in under normal circumstances down there. And so now if you're going to cut out other hospitals down there that their patients have access to, that's going to bog this whole thing down. And so it's going to force patients to get stuck in these referring hospitals that are sending patients to them. And that's going to create a huge problem. So anyway, I'll see what he comes back with. But if that doesn't work, then, we'll move up the chain rather. And, if I have to go legislative or whatever, or if I've got to go to the Department of Managed Care Services or whatever, we'll do what we have to do to get some resolution on that. I certainly understand their issues. I know on some of their outpatient stuff that they've been doing this on, obviously because they want to control their costs. It costs more to have certain procedures done here at the hospital and any inpatient hospital than it does in the freestanding imaging centers or labs or things like that. But again, that some of these other things are much more bigger priority for me. But we'll continue to work on that. The water board, yes.
On that issue, I'm sorry to stop you, but
no problem.
At what point do we need to step up and say this is affecting the patient's health, and make a medical decision to admit them here or provide the procedure they need here, and not wait for their approval?
We're doing that anyway, because we have the patients here waiting here in our hospital. We're going to care for them no matter what.
Good.
And so like I said, my bigger concern is, like I said, if there's a service that we can't provide that needs to go down there, and I'll be the first one on the phone, with the CEO, if that's the case. And I have told the ER doctors to do that. They will call me at 2:00 in the morning if they have issues getting a patient transferred or whatever. It's and I have all of their CEO's cell phone numbers, and I've called them. And I know Russell Judd from Kern Medical's gotten a few calls from me. So, it's just what you got to do. It's patient care first. The rest of that stuff, the money is important, don't get me wrong. But the bottom line is, right at that moment, it's about the patient, and that's what has to be dealt with.
It has to be.
So,
good.
So that will always be the case.
Great. Thank you.
You're welcome. The water board issue that I raised last month, regarding our testing of the wells around our treatment plant here, has been resolved. We only knew of 9 wells. Apparently the county said we had 11 wells that we were supposed to be testing, one of which we found buried under the dirt up on McRae, north of the hospital here, or I guess it's south of the hospital. And then the other is actually out in the lake when the water levels are up. And so that one could not be found. And luckily for us, the county water board basically said, forget that well. I know Scott Kissick had allowed us permission to go test on his property or drill a new well on his property if we needed to. Luckily, the county reneged and just said, forget it. So that's been good. All 10 wells now that we have been run all the full tests on. Those reports will go to the water board, I believe, in April for the first quarter of this year. And we should hopefully be fully compliant with all that. So that was, I'm glad that worked out the way it did. The state and federal agencies, the CDPH and CMS, are going to begin their licensing surveys and other types of surveys beginning, I believe it's April 1st. They've continued through the end of this month to hold off on going in and doing anything but immediate jeopardy type surveys for significant patient care issues and things like that, or infection control. We've had several of those, and we've done well in all of those. So again, we are due for a licensing survey for SNF. I know Sally has been working very hard on trying to get prepared for that. I mean, we technically are always ready, but there's always prettying up you got to do and make sure you've got all the loose ends tied up. But so that's in process. I wanted to also announce the hospital did receive a notification that we were entitled to a HQAF payment. It was about just under $4.5 million. Last Friday, I picked up a $4 million check from Kern Health Systems. There's another 400 some odd thousand that's due in from HealthNet. I don't know if we've received that yet or not. Should be coming soon, I would imagine. Anyway, the HQAF is a hospital quality assurance program. It's basically a tax that is charged to certain hospitals around the state each year. We are exempted from that tax as a small rural hospital. And so those monies are ultimately used to be given out to other hospitals around the state who predominantly have a higher Medi-Cal population and uninsured population. We have qualified for that. And so this was actually, I was reading through that today. This was actually this HQAF was actually made a permanent part of the California's reimbursement structure. And it was done back in 2016 with resolution, I think it was 52. That was put through. So this is going to be an ongoing thing that we participate in. And so it's primarily to increase access to, for Medi-Cal patients as well. There's also a portion that goes towards children's hospitals that ensures that there's access for Medi-Cal patients for children's care and so forth. So this was a really good thing. Just, glad that we participated in that. I think we've gotten these before. This was a 18-month program, as I understand. And the last thing I had on my list was received notification today that we were eligible to participate in a donation from Walmart Foundation. They want to donate money to us to provide a hot meal for every one of our employees sometime within the next 30 days. And they want us to use a outside vendor, but they want it to be someone in the local community to provide those meals. So they want the money to funnel into the local community. And so I approved that our participation in that thing tonight. And so hopefully that check will be coming very shortly. So we've got 30 days from that point in which to get a meal out to all of our employees. So I thought that was very, very nice. So we will make sure that we recognize the Walmart Foundation for their generosity.
Is that all employees or good employees?
They said all employees.
They're all good.
They're all good, that's right. So that's my report.
Thank you, Tim. Any questions for Tim? All right.
So that was an 18-month program.
Yeah.
So we can figure on yearly getting about 3 million or so.
No, it changes.
It changes.
all the time.
It does.
Based upon, yeah, on how much gets paid into the program and stuff like that, because it's based upon utilization. There's a formula for how it's calculated based upon Medi-Cal percentages, and a whole host of other things. I got a list of those things. But yeah, it changes from year to year.
Well, it was good this year.
It was good.
Yeah, that's good this year. Okay, Chief Nursing Officer report, Mark Gordon.
Well, good evening. Pardon me. Our latest audit of COVID positivity rate through the emergency department shows an obvious surge to almost 6% in December and January, with a subsequent decline in February of less than 1%. We're testing approximately 40% of the patients that come through, and the numbers speak for themselves. The community positivity rate dropped to about 3.28% last week, and the testing numbers are dropping off, as Tim mentioned, with only 55 that were actually tested today. We have had 22 staff members over the course of the last 6 months or 5 months who have been out at various times. So there have never been more than 3 or 4 out at a time. So just wanted to mention that. The local health officials have allowed us to return to a green level in the skilled nursing facility. We were at a yellow level when there was 1 positive employee through there. And what's required is to return to a green is 2 consecutive negative test results on all the residents and staff. So we've been returned to the green status. We've gone into the yellow status twice, I believe, and that was for staff. So anyway, and then finally, the plant operations manager has advised that we have 5 or 6 hospital beds that are kind of unserviceable and irreparable based on their age and the fact that there's no parts available for them. So I'm putting together, I've prepared 2 CERs, one for 2 beds for acute care and one CER for 4 beds for skilled nursing facility. I'm going to be presenting that to Finance Committee this month to expedite their replacement purchase. And we'll also present them at the Auxiliary Committee next week to see if they'll cover that cost for us. And that's my report. I'm sorry.
What's the cost approximately?
The acute care beds, 2 acute care beds is $11,000. They're about $5,500 a piece.
Okay.
And the skilled nursing facility beds are about $3,400 a piece. They're not, they don't have all the alarms and things like that. They do go lower to the ground so that when residents don't fall, they're only about 10.5 inches off the ground, which is
Pretty darn low.
pretty low. But those are, and I got a quote for 4 of those beds. So, and they're about $3,400 a piece. That quote was for around $17,000 total.
Thanks, Mark.
Yep.
Any other questions or comments for our Chief Nursing Officer?
And if I could just dovetail a little bit off of what Tim was talking about, just regarding the transfers of those patients, there are significant delays, but we are able to maintain a certain level of care within the emergency department to care for those individuals. We just can't advance their care, I suppose is a good way to put that. So it's really delaying some patient care aspects.
All right. Thank you, Mark. Okay, then we'll move on to our Chief Financial Officer report. And if I understand this correctly, Barbara, you're giving this tonight?
Yes, I am.
Hi, welcome. Thanks for being here.
Since Chet's tied up, can we just waive the reading of it and take questions? I mean, it's all there.
And Finance Committee's looked at, and they've all been in Finance. We've got members from the community that might want to listen to some of that stuff, but show you over.
Okay.
I'll be brief.
Okay, good.
If you go to page 18 in the packet, it is our volumes for the month of January is what we're reporting on. Our average daily census on the acute floor for the month was 6.5, with 5.1 of those being in acute beds. The long-term care had an average daily census of 49.6, which year-to-date they're at 49.2, whereas last year for the same period, they were at 55.4. The emergency room visits are still down. They were only 447 for the month. Year-to-date, they're at 3,554. The previous year, they were at 4,367. Outpatient visits are still up because we count those visits for testing and for the vaccines that are given. There were 1,361 visits this month. The clinic visits were a little below budget this month at 1,255, but they had 390 visits in the mobile van in the month of January. They also had 300 specialty visits. Those are the telehealth visits by the other physicians. And the retail pharmacy filled 3,220 scripts for the month. And year-to-date, they're at 23,094. And does anybody have questions regarding the volumes?
If you do a better job, then Chet won't be out of a job, will he?
No.
Okay, cool.
Chet just may ask Barbara to do the meetings all the time. And he can add his comments. That's right.
So if you go to page 19, that's our monthly report for January. Our revenues were $9,652,000 under the budget. The acute care inpatient revenue, with all the patients that we had in acute care, their revenues exceeded the budget. Our total operating revenues after deductions were $2,435,000. Our expenses were $2,623,000. And for the total month-to-date loss was $132,401. Does anybody have questions regarding the month?
So it's my turn to grill Barbara for a change. I just had a quick question. You said the acute care. Now, is that what's in the other operating revenue? Is that what you said? The 135?
No. The inpatient revenue.
The inpatient revenue is, I see. So that exceeded the budget. Yeah. Okay, gotcha. Okay. That's all.
Inpatient revenue is just high for the month because of the patients.
Okay.
More expensive. Yeah.
That all?
That's all. Yeah.
The following page is the year-to-date. We are $4 million below in our revenue. Revenue is $66,956,000. Our total expenses were $17,852,000. This is for the year-to-date. And so that is giving us, with the loss this month, a loss of $909,000 year-to-date. Anybody have questions on that?
So Barbara, this is Ross. I do have a question, and I know this isn't reflective of last month's report. But the $4.5 million that we weren't expecting, is this going to show up on our financial reports as part of operations ongoing next month, or when we do the February report, or is this going to be not accounted for until the audit?
Some of it will, and most of it will be not accounted for until the audit.
Okay. So you're adopting the doom and gloom approach that Chet.
No, she said some of it was coming across the
I take my instructions from Chet.
I'm sorry. I just wish there was a way for us to reflect this, because it's revenue into the district that we have earned. It's just not being reflected in the monthly reports.
No, it's like more like a bonus, not necessarily earned.
We should-
Well, we wouldn't get it if we
It's
didn't earn it.
supplemental income for taking care of low-income patients or low-pay patients. I mean, that's, so.
It's.
I
it's
can answer
Medi-Cal-
that.
It's Medi-Cal
I'm here.
payments to services that we've provided. So, it's not a bonus.
An indirect one.
Yeah.
Are there any other questions? No? If you want to look at page 24, it's the cash flow page for the month. And this is cash from operations, and some of the other miscellaneous cash shows up here also that we received. We collected $2,460,000 and we paid out $2,574,000 for the month of January. And so our net operating cash was $732,000 for the month. Any questions? You don't want me to go into the,
No, let's get into that. We've gone into that detail already.
okay.
That's the question.
That's all the report unless somebody has questions or needs more information.
I did have a quick question on page 26, which is of course the bond requirements. Now, is this page going to go away, or is it going to be like a new page?
It's going to be a new,
New page.
It will be a new page reflective with the new refinancing that we did.
Yes.
Okay. Okay. But it'll be very similar, kind of the
It'll
same
be-
kind of,
yeah,
okay,
depends upon what the rules are.
okay.
Yeah, we just want to make sure that we're tracking towards that as well.
Sure.
And again, recognize that again, what's counted ultimately is our year-end audited numbers.
Okay.
So, I mean, that's where all the extra money goes in that ultimately rolls up. So that's how we are meeting those requirements for the bonds.
Okay.
Any other questions or comments for Barbara? Hey, gold star, Barbara. Thank you. Okay, item F, old business, Alta Sierra Broadcasting Proposal. Tim,
What page is this?
44.
Oh, thanks. As we shared before, and as we talked about in our strategic planning process, we wanted to go back and refocus some of the monies and what they were spending on marketing and so forth. And we basically went down and we pared down by about 25% what was being spent on our radio ads and so forth. And we wanted those to focus primarily on the time slots that people were actually listening to the radio, which turns out to be early morning and around noontime hours. And so forth. And we brought, and we've got updates for all three of the radio stations. At Finance Committee, we were asked to go back and take a look at focusing the bulk of the money and time slots during the hour, on the channel that actually has the most listeners. And so we did do that. And so the request now is for $600 a month for the KCNQ, which is the country station. Then there's $150 a month towards KVLI, and then another $150 a month to KRBQ. And again, it's primarily focusing on those time slots that we asked them to. So I'm pretty comfortable right now in going ahead and requesting permission to go ahead and execute these requests or these broadcast orders to get started.
Can I make a motion or do we need discussion? I make a
We can go
motion.
ahead and make the motion. We can have discussion after that.
I make a motion, we accept the proposal. Looks good.
Thank you, Gene. Is there a second?
I'll second, Ross.
Thank you, Fred. Okay, any discussion? Are there any members of the public that want to be heard on this item? Okay, then we'll take a vote. Director Blythe,
Yes.
Director Parks,
Yes.
Director O'Connor,
Yes.
Director Clark,
Yes.
and I'm a yes. So we're moving right along. That takes us to item 4 under new business. This is the memorandum of understanding with California State Loan Repayment Program for one of our pharmacists, and I'm not going to attempt that name.
Lie.
Okay. Greg, I will turn this over to you.
So this is a
61.
this is a contract that normally would have gone through finance before it came here. The reason it's coming straight to the board is that this was last minute funds that were available from OSHPD for loan repayment. We've participated in loan repayments for several of our practitioners in the past. This is the first pharmacist that I know of that has been awarded this. This is a 2-year grant. It's a $50,000 total grant, not a grant. It's a
Loan repayment.
it's loan repayment. We provide $25,000 payment, and the state matches that $25,000 payment. We're entitled to this because we're in a medically underserved area and we're in a health provider shortage area. So we're fortunate to be able to qualify for these programs. While we are potentially eligible for National Health Service Corps, our scores aren't really high enough to award loan repayments, but that may change soon. So that's basically the gist of this this contract.
Is that the pharmacist in here or is it the one at our retail?
It's our inpatient pharmacist. He also provides outpatient care, which entitles him to this.
He's awesome. He's a great pharmacist. Can I make a motion that we do this?
Yeah, he actually moved here to Kern Valley. He actually lives here
Yeah,
locally. So
he's real. He's good.
So
Gene
one
made a motion.
caveat that I wanted to bring up about this is that the actual agreement lists me as the signer. So it would have to be, I know Tim typically signs these, but this one needs to have a special acknowledgement that I'll be the one signing this contract tonight if you approve it.
Okay, can I make a motion we approve it?
Do we have a second?
Does that motion authorize Greg to sign the agreement on behalf of the district?
Yes. Yes.
Thank you.
I'll gladly second, Ross.
Thank you, Fred. Any discussion or questions? Any member of the public wishing to be heard on this matter? So Greg, I do have a question. What's in it for us? Why do we want to pay 25,000?
We retain staff. The cost of recruiting a pharmacist or a physician or a PA or nurse practitioner can be very expensive. These programs entice people to come to this area. So Lai asked me the same question today. He says, well, what does a district benefit like tax wise or anything? He's almost feeling guilty that we're considering participating in this, and I told him the exact same thing that I just said. It's retention of qualified people that will be here for a long period of time.
He was at the strategic planning, if I'm not mistaken.
That was
Seacon,
that was a different one.
Oh, is it a different one? Okay. But
Lai is equally capable.
Yeah,
He's very, very competent. He handles our MERP meetings and everything else. He's great.
So it's in terms of our return on investment, is definitely worth it then.
I agree.
yep.
Okay, Gene, your vote.
Yes.
Fred, your vote.
Yes.
John,
Yes.
Catherine,
Yes.
and I'm a yes. Thanks for bringing that up, Greg. Okay, our budget assumptions. The fiscal year 2022 budget assumptions, and Chet is listed. Is that you, Barbara, or Tim?
You want to handle it?
What
I
page?
can. I didn't know I was going to, but
I'll handle it.
actually it's all in the packet beginning on page 65.
This was reviewed at Finance Committee and so forth.
Yes.
So, and I think most everybody was there to hear
And
that.
it pretty much, the dissertation tells you the steps that we will be going through and the changes that we will be making and how we're going to be arriving at the numbers before we bring the budget back to you.
Right.
Um,
We're not voting on this tonight, right? Or
Yeah.
anything.
This is an action item, yes.
Well, these are just the assumptions.
These are the assumptions, that is correct.
Right.
Yeah, we do the budget in June or July.
Correct.
Right.
Well, we're
Well, take
starting
effect.
now, and so we're going to do it in different steps. So when
Oh, that's right.
one step is complete, then we'll bring you back the product to approve.
It's like every month there'll be a new piece of this that gets the capital budget, the staffing, the whole bit.
Yes, yes. It'll all come back individually, but this explains everything. I don't know if everybody looked at it or if they have any questions on any of it, anything specific. It's pretty much taking our history and rolling into the next year with those assumptions.
Was any market issues that we know of or things like that that will be coming down?
It's difficult for assumptions with COVID.
Yeah, very much.
Very difficult thing.
Mhm. And the page on the back, page 72, is the estimated volumes right now.
Well, that's the next one on the line. That's a separate action item.
Yeah, we're not quite there yet.
Nice.
I understand your desire to rush that.
Yeah, that was a nice try.
Nice try.
Any questions for Barbara on the budget assumptions?
I guess I just do have one quick question. I know even when I was on the finance committee, I know we've talked about it over and over. I know Gene has made comments about, how can we improve the retail pharmacy? But that's the one thing that does stick out on me in the assumptions is how, we have this issue of trying to maintain the profitability and controlling the costs. And I think it has gotten better a little with the cost controls,
Yes, yeah.
but
We're gonna deal with that pharmacy, I'll guarantee you.
yeah. Well, and I know the community loves it. I mean, they really do love it, but
But we owe it
Gene's
to the
pet
community.
project,
We're gonna
Okay.
do it.
okay.
Trust me. We couldn't do it last meeting.
Yeah.
It's gonna happen.
That's just the one thing that kind of just,
Yep.
I mean, I don't have many, pro or con about it, but it's just a, forward looking kind of thing, I guess.
The 7% increase in rates that seems to be that we do this every year, 7%. I'm not sure what the basis for that is. I'm sure there is some basis. I just don't know what it is. But
We do it
it makes our prices go higher.
Yes.
And I suppose there is some return on investment, but Medi-Cal payments aren't going up. Medicare payments aren't going up. So what do we get? Why do we increase our rates by 7% when we know we're not going to see that on 80% of our payers or 90% of our payers?
I think he's asking you.
Yeah, I know.
Chet, like Chet said.
Well, on those that we do get a return, then it's better to increase and not to do anything at all. And you cannot increase to one and not to all. You must increase across the board.
And I think, and again, I don't know that it really impacts the inpatient as much, but most of it hits on the outpatient side, if I would imagine, because some of them still might be percentages, again, that's really the only reason why you would do that. But, again, they're right. I mean, technically, again, a lot of our business is either fixed because of Medicare or Medi-Cal, or the managed care stuff is all negotiated rates. So, there is there used to be, I mean, this was the thing everybody did every year after year, but there is still a very small slice of the business, I believe, that still is impacted by that. Like I said, I agree there's an optic there from a community perspective that your prices are astronomical, but and that's what people think, oh my God, you made all this money, but you don't. I mean, when you actually look at the bottom line, it's very little of it actually falls through.
Somebody without insurance will have to give us their firstborn. What it's down to.
Well, I know at some point because we're a critical access hospital, pardon me, that we get backfilled by Medicare on what our actual costs are. I just wondered if this 7% increase is a critical factor in going into proving what our actual costs are.
Well, it's based on cost though, not revenue. So it doesn't really matter what the charge is. It's really what your costs are to factor that. So there are certain things where the cost to charge ratio does apply.
This is something that we will need check. Can we approve this and then talk about it next, at the next meeting if there's questions for it? Because Chet's the one who knows.
Well, Chet presented it at finance.
Okay,
too.
okay,
Yeah.
okay. And we
I'm not on the
can-
finance committee, sorry,
We
folks.
moved it onto this one here.
Okay, I'll make a motion and we approve that as presented.
Thank you, Gene. Before I stop harping on this, I know that part of our strategic plan, we wanted to make some services that were a lot more affordable to members of the community, like our radiology services and lab services. And as we continue to increase this 7%, just kind of as a rote action, we make that harder to achieve. And so I sure would like to reconcile this somehow. I know that we had supposedly engaged Whitfley to help provide some input on that, but I haven't heard anything back. And since we're talking about the budget assumptions for next year, I guess I'd kind of like to get an answer on that.
Ross, I do remember him talking about specifically the radiology, getting a new contract with the providers, everyone, Qualcare and all of the ones that we mostly see, plus the Medi-Cal. I think isn't he working on, he works on those contracts and specifically for radiology to keep more in here. So I know Chet's working on those, right? So.
Okay. Well,
I mean, if there remains to be questions, again, I mean, I know there's a budget cycle and there's a process for going through these. If this was not approved tonight and they wanted to bring it back for more discussion, could that be done, but yet still keep moving forward with the other budget things? Okay, so that is a possibility, Ross, if you still want to take time to discuss that. We don't necessarily need to approve this tonight, but the other aspects of this are important for us to move forward with the budget.
Well, but that could be changed too.
Yeah, but these are just the assumptions. So I mean,
Right.
it doesn't necessarily mean.
So he could go ahead and bring that down after we discuss it.
Yes, if next time if we decide to do that, we can do that. But like I said, once you approve the assumptions, then basically they're going to build a budget around those assumptions. So, but the other aspects of this, like the capital and, obviously some of the other expenses and stuff that are driven by the statistics and volumes are important from a budgeting perspective. That work can continue if the board wanted to relook at some of those assumptions. So, I mean, a vast majority is I'm fine with, I agree with them. But that one has always been an issue for me, but I certainly understand why it's done. But
after COVID, everybody will be afraid to get sick. So we're going to have problems.
it has implications, obviously, for the public. Obviously, that went into effect in January 1st was the transparency regulations, which now, before we had to list our hospital charges on our website and so forth. This year, they went back now and they changed the rules to say that not only do you have to put your charges out there, but you have to list all of your contracted rates for certain procedures that are done, what they call shoppable procedures, and so forth. And so that people can compare them, they can look and see what it costs under one contract versus another contract or whatever. It's a huge amount of work. And every hospital in the state has to do this now on their websites. So, there's implications there, obviously, what we charge for cash paying patients that come in. We keep raising that rate, but we only give a percentage off of our charges. That's where it becomes difficult sometimes for our community to afford to come here if they're paying cash. And there's aspects of that that we can get into in finance committee. Because I really would like to dig into that, because we have a fixed percent that we do, but yet we're contracting for lower rates with the health plans on a lot of that business. So I'm going, well, if we're willing to accept that low rate for those contracts, why shouldn't we be offering that to people who don't have insurance? You know, so some conversations I think we still need to have on some of that stuff, but.
I agree. So, you know, I don't want to stop this from going through tonight, but it's a broader issue that I think we need to address.
You're not hearing me.
No, we can hear you.
Is that you, Chet?
He just dropped off.
Just dropped off.
I don't think he knew that we heard him, so
Okay.
he'll probably try and call back in.
Okay, we can table it till next,
I mean, we can, that's why I said, if we want to have more discussion, we certainly can do that.
Yeah.
maybe we should, maybe I should withdraw my
I was
motion.
just gonna say, you had a motion on the table.
How do I get it back?
I rescind.
Yeah,
my-
I don't want to put a monkey in the wrench.
Like I said, I
Stop
think
the budget process.
well, like I said, the budget process will continue. That's what I was saying. These are assumptions that will be used, but there's so much other work that goes into this that we have time to bring that back. I don't know that we
Okay.
would want to go more than next month's meeting before we finalize that, but
We can all go by Chet's house tomorrow.
out by the pool.
Okay, does anybody have any objection to this item being tabled until next month?
No.
I don't.
All right, let's do that then. Thank you. And then the next item, the budgeted statistics and volumes. Do those go hand in hand with the percentages and budget assumptions, or is this vital to be done today?
This has already gone out to the departments. It's an average, giving them a 4-year comparison and an annualized number and an estimated based on that history, what the new volumes will be. This does not necessarily, it's going to drive our revenue, but it doesn't have anything to do with the percentage of increase necessarily.
Yeah, this one here, I'm good,
This is
Ross, with
citizen
moving forward,
service.
because this actually has the meat of the budget process behind that.
What
Okay.
our expenses will be based on the volumes, what our FTEs will be,
Right.
things
Okay.
like that.
All right. So is there I'll entertain a motion to approve item 6.
Somebody has to make a
And-
motion besides me.
This is also the projected amount. The individual departments all have their schedules, and they have input into whether or not this is a reasonable number, a doable number. They want it bigger, they want it smaller, whatever they're seeing happening in their department. They have a say. So some of these numbers could change when we come back with the final budget.
Makes sense.
Can I
Sounds
make
like a
a
good
motion
process.
again then?
On motion is presented, Ross.
Fred, okay. And Jean, was that a second?
Yeah, that was a second.
Thank you. Okay, Fred, your vote.
Yes.
Jean, your vote.
Yes,
Catherine,
Yes.
John,
Yes.
I'm a yes. Okay, so that brings us to item number 7. This is the Tri-Cent Secured Split Dollar Program. There isn't detail in the agenda packet. This was discussed at the governance committee, and the purpose of putting it on the agenda for tonight, pardon me, is not for formal action by the board. It's just for an opportunity to discuss the concept and to understand if the board wants to move forward with further explanation of this concept. So I turn it over to the board for discussion.
Ross, I believe that we need to take a step further to find out what the exact costs are going to be for us to get this implemented from the start. And just start to weigh those options. We need to have some numbers to work with before we can even have any type of true discussion on how to proceed.
Okay. So you don't have objection with the concept, but you need to see numbers.
Correct.
Okay.
Well, the overall, the program is most effective for someone that's paying a lot of taxes and they want to defer some of them.
No,
We're
it's
not
got
in
nothing
that
to do with it.
situation.
Yeah, it's got nothing to do with that. What it basically is it's a means for providing additional monies for me. In exchange for me doing this, I give up any future raises that would be considered here. Again, I'm at a point where I'm more concerned about being able to survive when I retire, you know, and the nice part about the way this program is structured is that the hospital district contributes the money into that. It creates two insurance products, one of which it sets up the monies that would come to me later on. The rest of it makes sure that the district gets paid back 100% of everything that's put out, plus interest.
Correct.
So we
Plus excess.
would be $1,500,000 would be guaranteed to get back.
Well, based on that model,
Based on the-
yeah, that was purely on the numbers they chose. That may not have anything to do with what we chose.
Be worth looking at,
So,
but. You know,
But the nice part about it, because it's carried on the books as an asset, not as a liability. You know, and again, everything is paid back to the district. Again, it's a great program. I know we've done it for the CEO at Kern Health Systems. We've done two of them for him to extend him. It's a great retention tool to keep them to stay. And so, like I said, I'm very interested in the product. I've seen how it works. If this is something the board's good with, then I would be very happy.
If we
with it.
did something like that, could we pay you what you're worth?
You do now. I'm willing to forego any future increases you've been.
But we should look into it.
Yeah, like I said, at finances said the same thing. We really kind of need to know what the numbers are. So I appreciate that.
John, Catherine, you have any heartburn with further exploration of this concept?
Are you planning on leaving? Is that why we're trying to retain you or what?
Well, you know, my point is, like I said, the point was to try and convince me to stay until after the construction projects are over, you know, for at least 7 years. I'm sure my wife would love to have me there around home more, but no, like I said, it's something that I personally want to see happen. You know, I'm committed to, you know, with all the work that we've put into making this thing happen, you know, I want to be here and I enjoy what I do, you know, but, so yeah, it keeps me here.
We got to look at all, there's a lot to look at. And
Right.
And the value of him and the value of what he's losing by not getting a plan. If I could just, when I said to him, I was worth the first job, whenever I was younger, I went up and I asked the guy, I says, you know, can I work for you? He said, yeah. And I said, well, you pay me. He says, well, I'll pay you what you're worth. And I said, well, I can't work for that.
Yeah, well, yeah, I would like, I mean, I was in finance and so I heard, you know, what it is, but I would like more numbers on it. What the cost of this would be. And I understand that it's 100% we get back.
Yep.
With each raise we give you, we don't get that back. Hopefully we get.
Well, he won't get any more raises. So
Right, that's
it's
what
all
I'm
a big-
saying. So it's a benefit that direction.
Sure.
So, but yeah, and finance was the first time I had even heard of a program like this. So I personally would like
Yeah.
just more
It
information.
is used mostly for an owner of a company to set aside taxes and everything.
Okay.
Not
Not me.
putting
Yeah.
this- yeah,
Right.
but there's use for it. And maybe there's use for it here too, but
Yeah, this was actually, like I said, you know, came from the Hospital Association was the one that sent this out to all the CEOs a number of years ago and so forth. And a lot of the higher ups within CHA are on this kind of a plan. And the head of the hospital council, who's a subgroup of the Hospital Association, sent this out to the CEOs in his area. And, you know, again, it's a great tool. I mean, the way it's structured and everything else, it's great for the district because not only do you get all the money back, there's additional funds that come in from it as well. It works good for the CEOs. It works good for their families. Because again, if I pass away, my wife can continue to receive, it's only a benefit for so many years. But if I die before that, it would continue on until the end of that period that she would continue to get that monthly, you know, payment as well. And then it ends, you know, and then the money comes all back to the district and stuff like that. So
So he,
like I said, I think there's a lot, it's a complicated program. And I think, you know, again, even myself, is this something I really want to do? I need more information, you know. Like I said, I know how it works there. I have no idea what the numbers would look like for me, you know, so whether it's worthwhile or not. But I'd like to
And
certainly explore it.
So how do we get that information? Is
We
that,
basically will sit down with Tri-Send, you know,
Okay.
through Ross and Chat and everyone else.
Okay.
And
well, not everyone else, who would sit down?
well, we'll collect the data. Like I said, we can do it at finance committee or whatever, you know, I don't care. Or we can do it at governance, you know, and but ultimately all of the board members will get that
Right.
information. So you would have to.
I'll
So-
begin the conversation, but we'll share it through governance or through finance,
okay,
probably both committees. That way, we get
Yeah,
two
everybody's
different
input.
perspectives on it.
yeah, we
Right.
certainly want to help them if we can and help ourselves. I mean, but see, we just need to see.
Absolutely.
Well, and I totally agree with helping his wife and child. If something happens to him, that would be my main goal. And that's what I want to understand about it. Because I think that's the reason for this program in the first
For me,
place.
yeah, it is. Yeah.
So that's, and I agree with that. It's just, I've never heard of it. So I don't understand the program and I'd like to just have that.
And it's complicated, so you're right to question. It's different. It's a
Now,
different, it's a different
Russ-
animal.
Russ, he didn't share any thoughts about maybe having some really bad situation if this construction don't turn out the way he tells us it will be. That he might need a life policy.
Well, I'll share with you. I mean, the incentive is high for me to stay. Because if I leave, if I choose to leave, I lose everything. So that's the incentive. So I'm tied.
Yeah.
So, I mean, it's a strong program from that
Would
perspective.
you take me with you if you leave?
Do I have to? I might have to run that with
Wait,
my
we
wife.
could make a
That's
deal
right.
here. Just putting that out there. Okay, yeah.
You know, but really what motivates me to pursue this is, you know, we've just committed to a big loan
To a lot, yes.
this evening. And we've got, you know, this big construction project coming up that's going to be complex, and switching horses in the middle of the stream would not be beneficial for the district. And so I would love to see Tim's leadership continue on through that project. So we don't have to deal with leadership change in the middle of a big complex project like that.
But you know what, I just want to put out there so people know that if something like that happened, it's not anything that we cannot handle and work through.
No, it's doable, but man, what a headache it will be for this board.
Yeah.
Well, just get in line, but I'm just saying that
Yeah, no, you're right.
have,
You're right.
as much as we want to make sure that his
Sure.
wife and child are cared for, that we need to have the ability to know that it's not anything we can't work through if we have to.
Oh, absolutely.
Everybody's replaceable.
Yep.
Everybody's replaceable. They are. Okay.
So
Thanks
you'll
for your
start on
feedback.
getting that numbers, you'll start with that process? Okay, thanks, Ross.
Yeah, we'll start building some details on it so we have a better understanding of what we're really talking about.
Okay, thank you.
What we need to do the same thing for this guy over here too, because he's got to be here through the whole thing.
He's out of camera. Who are we talking about?
Bob Easterday.
Yeah, definitely.
Do you guys as a couple?
That's great.
Okay, so we are moving on to item H, the director's comments on items not appearing on the agenda. And so let's start with Catherine.
You know, I just want to let everyone know that I'm just grateful to be on the board. Took me a little while to get here, not as long as John, I don't think, but it took me a while to get here, but I know he was determined also. And I'm really grateful just for the knowledge I'm getting as I go to attend each one of these meetings. There's a lot more to it than, I mean, I knew there was a lot to it, but when you start looking at all the numbers and all the information, it's a lot. And I just want to let you know that I am going to do my best to understand it and make the right decisions.
Thanks, Catherine. Fred Clark, any comments tonight? Oh, you're muted, Fred. Looks like you're muted.
No, I'm not muted. I just want to tell you the learning curve is fun. I have to admit, I've done more reading in the last 3 months than I've done in the last year. Keep it coming. I'm having a good time.
Thank you, Fred. Gene?
One thing, the employees here are absolutely awesome. Everybody, Greg's group, everyone that works here. And some type of combat pay, I talked about it at Finance Committee meeting, and Tim said that he would look in to find a way. I proposed that we give a percentage of that $4 million too that we got. And I know how courageous these people are. They deserve some compensation for what they've done, for showing up here at work every day, and they're awesome. So Tim is you're gonna try to find a way to do something, right?
Yeah, and it most likely probably won't come out of that $4 million.
No, I know.
Yeah, primarily because, like I said, there are certain things
Right.
that have to be used for Medi-Cal access and those kinds of things.
Right.
So I've actually contacted the Hospital Association, Ryan Witz, who is their VP for hospital finance issues, who formerly worked with Medi-Cal. And so I've asked him to kind of give me a report on how and what we can use all of these supplemental funds that we receive. So, and I'll make that available to everybody. So, because it gets complicated. I mean, we kind of need to know what our flexibilities are with any of this stuff before we go out and try to say, hey, we're gonna go do this or whatever. So,
Well,
it's
we're making an effort, and they more than deserve.
Sure, sure.
And I know. So anyway, thanks everyone for putting up with me.
No, no problem.
Thanks,
That's it.
John?
Just reiterated like what I've said the last few meetings. Thank you to Tim and the staff here for everything they're doing during this pandemic. And it's nice to see you, Catherine, at a board meeting in person for a change.
Thanks.
Nice to see you.
Thank you. I appreciate that. Like I said, my dogs are starting to hog the screen, so I had to leave them at home. Jeez.
That was funny.
Thanks, John. Hey, on the item that Gene was talking about, the reward to staff, one thing that input that you might get from the hospital council, or at least ask them about, is since we're a public agency, I don't want to step over that line where it's a gift of public funds. And I think we need to be really, really careful about that.
That's a great point. And you've got Scott here. I mean, we can certainly have him weigh in on that right now, if he would.
Yeah, so the laws regarding compensation for public employees are very straightforward, and they're pretty strict. And the underlying principle is that at the start of each employee's anniversary year with the district, that they accept they accept the compensation that the agency offers them at that time. And unless you have a bonus structure agreed to ahead of time, you cannot retroactively give bonuses to public employees. Now, an exception would be if you get funds from the state or federal government, and the agreements for those funds explicitly allow you to use them for employee bonus programs or some other type of compensation for employees. But the general rule is no retroactive bonuses. You can't get a windfall and decide to share it with your employees. But you can set up a bonus structure going forward. So we would have to find out from the source of any funds that the district gets as a result of COVID, if they can be used for those purposes. And if that would be permissible, then there would be a legal authorization to do so. But the district could not just take its own money and say, no matter how great the staff has been, and say, all right, for all the work you've done for the last year, we're going to give each of you this bonus. So,
Well, Scott, even Congress is talking about giving grocery store workers extra compensation because, in fact, I think they did even, and healthcare workers. So maybe we should go to Kevin and ask him to send some of the money they've got through him to us for them. And $2,000 or $3,000, but I think they deserve just a fair amount.
well, they probably deserve a great amount because they've done a lot of great work.
The last 14 months, if a couple $100 a month would amount to a decent.
Yeah, no question. But keep in mind that when the cities, like I believe it was Long Beach, authorized their hero pay resolution, or if Congress does something like that, those are explicit statutory authorities to use the money for those purposes. And that legal authority does not exist apart from those laws being passed. So if those laws are passed and the state of California says tomorrow, public agencies, you can give bonuses to your employees for all the great work they did in 2020, then more power to you. And that's the legal authority you need to do it.
This is above great work. This is courage that they what if they would have not stepped up?
That I totally hear what you're saying. So if the state said, absolutely go for it, then there's your basis for doing it.
Would it have to be state, or like if
State.
if McCarthy gave money, we couldn't give it?
No. If Congress allocated money for employees, then absolutely you could use the congressional money. But to change the law, the state would have to change that legal principle. But if the feds say, here's $1 million to give bonuses to your employees, then by all means do so.
Could we just give them cash?
You're going to have to run it through payroll.
Well, at any rate, we need to work on it if we can, Tim.
Yeah.
Okay, thank you.
We'll gain more information on that. Hey, another thing that Gene had brought up earlier in the meeting was the video recording policy. I know you were looking for some videos that were supposed to be posted, and I'm not sure they're there. I haven't looked.
I haven't either. I figured they were automatically done.
We did have technical difficulty with the last building and planning meeting. The meeting that followed immediately after we adjourned, when they logged in, it killed the conversion of our meeting for that building and planning meeting. So
What about finance? There's no finance meetings.
I probably need to get with Carrie to have it
There's
posted.
none. And there's
No
no
finance
building and
meeting?
planning for the last 3 months. None, zero. The
I know
only
this
one-
last month was a problem. The ones from
Yeah,
last
there's-
month should
Well,
be
the month
there.
before that, I didn't see it. I looked for it.
There's a couple
Oh,
of
I-
video.
Could you follow up and see where we are with those?
Absolutely.
And
I can look right now, just looking.
that's okay. I don't want to take any more time tonight.
No, we can do it before the meeting
And
ends.
it's fine. I'm not,
Yeah.
the public just needs to be able to look if they want. to.
Absolutely.
And
That's the whole
it's
point of
not-
doing this.
Yeah, if we're, we passed that policy, and so we need to be working towards compliance with that. I'm really excited about the bond that we approved tonight. It pays off existing debt that we have, or refinances it at a lower interest rate. Gives us additional cash for our construction project. Really excited about that happening and moving us forward and getting that done. We are securing really the future of the hospital and all of our services by taking this action tonight. So I'm proud of all of you for doing that. And Greg and crew, with your COVID vaccination program. Again, it's being so well received by the community. It's such a wonderful thing to have happen right here in our town. To see that mobile clinic out there working, it's highly visible, so people know it's happening. Such a good thing, such a good move, and your crew is beyond phenomenal. They're wonderful to work with. It's been such a good experience. So thank you so much, Greg, and
Thank you. I'll tell them.
and you too, buddy. You designed a good thing.
Thanks for coming out and helping yourself, because you've been a huge help with us. It's freed up other staff that can do other things. So thank you for your time.
Is there any board, Ross, is there any board members you want to say is good?
No. And the debt policy that we approved tonight, I'd like to see the finance committee take that on and look at it in more detail. You know, the policy that we approved tonight doesn't fit our normal policy in terms of its format and to fit into our policy manual. But beyond just the word processing part of it, you know, we didn't vet this through a committee. I'm sure we all read it, but we didn't beat it up like we would a policy from scratch. And so I sure would like to see finance committee kind of wade into that debt policy and make sure it fits Kern Valley to a T. So I guess I'm making a referral to the finance committee to put that on your agenda to review. If you could do that for us, Gene.
Write that down, but yes.
Super. Thank you all. Good meeting.
Ross,
Oh, he's back.
Ed, are you here?
kind of. If I could take a minute before you adjourn,
February's finance meeting.
I would.
The agenda, not the video.
Yeah, but those aren't there. I have to look at the video. That I didn't know.
I'm sorry.
Go ahead, Chet.
Oh, thank you. First, let me just say thank you for approving that policy and approving the bonds that we actually set forward. I think this is a kind of a deal that we're probably never going to see again. It's probably one time in a hospital's lifetime that something came up like this. So let me say that first. Thank you. The reason Gene asked why I wasn't saying something before. Well, I hesitate for two reasons. Number one, I had asked Gary to sit in for the bond items and Barbara to send in for me for the finance report. In addition, I was under sedation today, and I don't feel real comfortable about making a lot of reporting when I had sedation in that particular day, especially within the last 3 or 4 hours before the meeting. But I get to listen to it long enough that with some of the questions that I thought I'd just try to address them for example, okay, the raising of the 7% price increase each year. That's done by most hospitals. Let me tell you that about 70% of the services at Kern Valley, because of the nature of our patient mix, is supposed to be cost-based reimbursement. That would include Medicare, Medi-Cal, et cetera. What is not in that?
Hey, Chet.
It is, yes.
Let me interrupt you for a sec.
Sure.
You know, we've already covered this. And so I think we're straying actually a little bit with my management of the agenda. So I applaud you for.
Ross, he's not aware that he's not aware we delayed it for 1 more month. So
okay.
We're going to come back and have that conversation, Chet. So we'll be able to get into more detail with you when you're feeling better.
Okay.
I really appreciate you being here tonight for us, listening in. I don't think I would have been if I'd gone through what you did today. So thank you so much.
Yeah, thanks, John.
Okay, no problem.
All right. And so with that, then we are adjourned.
But I think he lost his job. I think.
See you all in committees and meetings next month.
Thank you.
Good night,
See you
everyone.
guys later.
What kind of procedure did Chet have?